we're going to go over opiate overdose, naloxone, also known as Narcan, and familiarize all of you on when we will be using this, why we need to use this, and who we are going to use it on. So our course goal is to provide all of you with the knowledge, ability, and confidence to know what to look for when encountering a person suffering from an overdose and how to best administer the medication naloxone. We do know that right now we do not administer this unless we are in the building. Our naloxone Narcan kits are located in the bubble in the AED kit located behind the sergeant's desk. In there you will have multiple Narcan kits to treat somebody who may be in an opiate crisis. That includes persons of the public as well as officers within the police department who may be exposed. So what is an opiate? It's a substance derived from a natural occurring poppy plant, which contains opium. The opium is the highly addictive narcotic drug that is derived from the plant. Common opiates include morphine and codeine, and they are directly made from the poppy plant itself. There are other ways to get an opiate, either by the naturally occurring substance or by means of being synthetic and chemically made. There are also semi-synthetic opiates, which contains half the natural opium poppy plant or half chemically made. Either way, these opiates act on our central nervous system as a depressant, which is used to decrease the perception of pain, decrease our pain reaction, as increasing pain tolerance. Opiates are prescribed either for acute pain, debilitating pain, chronic pain, or part of a treatment plan for persons of chronic back pain, cancer, amongst other painful diseases. Sometimes these opiates, as we all know, are abused to induce that euphoria or high. When one constantly uses opiates, the tolerance and or an addiction may occur, which requires the individual to increase the amount of opiate that they are taking to get that once same effect. So when you start using an opiate in the beginning for, let's say, chronic back pain, maybe that 5 milligrams you used to take 5 years ago no longer gets rid of that chronic back pain, and eventually you're up to, let's say, 50 milligrams over a certain duration. So what are the side effects when you take an opiate? Well, we know there's many side effects and each individual is different, but these are the common ones. We're going to have some respiratory depression. We're going to get drowsy. We might have some itching. We might have nausea and vomiting. Dry mouth, constricted pupils is definitely a telltale sign that somebody is on an opiate, and constipation. Most common types of opiates: codeine, fentanyl, hydrocodone, hydromorphone, heroin, morphine, Percocet, and so forth. You can see in the diagram here there is a multitude of opiates, some more common than others. With that said, keep in mind that just because we are not familiar with a certain opiate, that does not mean that the medication found on the counter or on the nightstand is not an opiate. We want to maybe look that up to ensure that we are not or are dealing with an opiate. So some statistics and data. We know the number of people in Connecticut dying from drug overdoses continue to skyrocket. Some 2015 statistics show that about 720 people overdosed with just heroin-related deaths. We know that we are in 2019 to 2020, that those deaths have drastically increased. Also, in 2015, data shows that 723 people died from just heroin and or cocaine or other drugs such as morphine. Of those deaths, 415 were heroin related, and about 107 of those were fentanyl related. The Connecticut Department of Public Health also currently shows that as of July of 2020, there were 666 confirmed drug overdose deaths this year, although there are other pending cases, so that number can increase. In 2019, there were 1,200 unintentional drug overdose deaths as well. We also need to keep in mind that there are other new and emerging lethal combinations of opiates, such as oxalizine, which is an animal tranquilizer, which is mixed with fentanyl. And in 2019 and 2020, these drug overdose deaths are increasing. So from 2015 to 2020, it has almost doubled, if not tripled, for overdose deaths. Overall, the number of drug overdose deaths are going to increase and continue to increase. So why do we need to know this? Well, we need to know this because we don't know if we are ever going to have an individual in our lobby get into an overdose or one of our officers. So sometimes when we're on scene or we're responding to a call, you may know that you're actually going to an overdose, or you may be told upon arrival, or you may find it once you get on scene. So first thing we want to do is make sure we have the proper body substance isolation is a top priority. We always want to wear gloves. Due to COVID now, we want to make sure we're wearing masks and the protective eyewear. Do we actually have the appropriate resources responding? Has paramedics been called? Is the fire department on their way? We do not carry Narcan, naloxone with us, so we want to make sure that on scene we do have those resources coming. When we're on scene, we want to know what the patient ingested, injected, or inhaled, or is there another way that this opiate was taken, which is by a transdermal patch, which we will talk more about in the upcoming slides. We also want to know if there's more than one substance used. We're going to look for some drug clues. A lot of you will see prescription bottles, and like stated previously, you want to make sure that what we are looking at is whether it is or is not an opiate. Are there other drug paraphernalia items on scene? Is there prescription bottles or pills in not the original container that we need to identify? All of those things on scene we should be looking for. So here in the top left corner, you can see the fentanyl transdermal system patch. That patch is used to give, let's say, the fentanyl or opiate of choice over a duration of time. So that package will be opened. You will see a little plastic square, and on one side of the plastic square you will have some type of gel or jelly on there that will have the fentanyl in it. So when you're touching these items, you want to make sure that you are wearing your gloves, because that gets absorbed over the body over a certain period of time. And if you can see on that patch there, it says 25 micrograms over an hour, meaning that patient is receiving 20 micrograms of fentanyl over an hour through absorption of the skin. So if you go to a patient's house or you're on a call for service and you see a square plasticky patch on the skin, keep in mind that that is most likely an opiate patch, which could have induced them into an opiate overdose. I know with my time working EMS, I've seen patients forget to take old ones off, which is why they go into an opiate overdose, because they forgot to take their old fentanyl patch off, and now they are in that opiate overdose. So make sure you check the patient's skin if you can't find any other signs of drug paraphernalia or prescription bottles laying around. Also going to look for packaged drugs, needles, plastic baggies, or any other drug paraphernalia. We're going to want to check to make sure and see if there's any signs of track marks or any other indicators that an opiate was used. Over time, somebody who uses like needles and heroin to inject the heroin into their arms, they're going to have a lot of scar tissue, and that they're no longer going to be able to use their forearms to inject the heroin. So sometimes these individuals will take their heroin needle and go in between their fingers and toes. So if you guys see any, blood or dots of blood near a vein between fingers and toes, keep in mind that is also an indicator of drug use there. So what are we looking for when we're looking at an opiate overdose in a patient? Well, we're going to find unresponsive or minimally responsive patients, and they will have a pulse. They will have a decreased or depressed respiratory rate. Agonal respirations, which are also like fish gulping respirations, those agonal respirations are not substantial to adequate breathing. If we do not correct these agonal respirations, they are going to go into the next bullet here, which is respiratory arrest. They will also have the cyanosis, which is a blue tinge around the mouth, and constricted pupils. If you have maybe one or two of these things, let's say constricted pupils and agonal respirations, you could have all or none. But keep in mind that if you don't have constricted pupils, you may not have an opiate overdose, and it might be something else. So what is naloxone HCl, also known as hydrochloride, or Narcan? The Narcan is the generic name, which is why you hear me say interchangeably naloxone or Narcan. So naloxone Narcan is an opiate narcotic antagonist that may reverse central nervous system and respiratory depression secondary to an overdose of opioids. So what does that really mean? That means that Narcan wants to go where the opiate is and to remove that overdose presentation that you will see. So the second bullet here, you see naloxone is not effective against respiratory depression due to non-opioid drugs. So obviously if someone's taken a whole box of Benadryl, an entire box of Tylenol, drank 5 bottles of NyQuil, naloxone is not going to work because none of those items are opiate related. So you're not going to get an effect to their presentation. It doesn't mean that this patient isn't going to have decreased respirations. It doesn't mean that they're going to be unresponsive. They could be unresponsive. They could have decreased respirations, but they are not going to have the pinpoint pupils that you would get from an opiate overdose. So when are we going to give this? Indications for naloxone use: respiratory arrest or hypoventilation, in addition to evidence of an opiate or opioid use. With suspected drug use, person is unconscious and has a pulse. Naloxone is for depressed respirations, not a depressed mental status. So what does that mean? We go to a call for service and we see a person who has a decrease in mental status that does not warrant alone the use of naloxone. Opiate use alone without depressed respirations does not merit the use of naloxone. So let's say we have somebody come into the lobby, they tell us that they just use drugs and they want to go to the hospital. We're not going to go into our kit located in the bubble in the AED unit and give it to them. It only is with decreased respirations and unconsciousness or in and out of consciousness. So naloxone dosage. Here is a photo of what a typical kit includes. These kits usually are used intranasally or intranasal dosage. Adults and children, their dosage is 2 milligrams within 2 milliliters. So you'll divide that as 1 milligram or 1 milliliter per nostril. So you would just push half into one nostril and push half into the second nostril. Infant and or toddler, you're going to do half of the vial, which is 1 milligram or 1 milliliter. or 0.5 milligrams, 0.5 milliliters per nostril. So it's just half of half into each nostril. Now, does anybody know why we would put it in both nostrils and not just shoot it into one nostril? Well, the reason for that is, let's say, our patient has a deviated septum, or their nose is clogged, or they just had surgery, and we don't know these things, and the Narcan is not getting into, the nasal passages, as you will learn in the next couple of slides. We want to make sure that we give an even chance for that medication to get into both nostrils in the event that there is a blockage. So why are we using it intranasally, or not giving it by IV, or not giving it in the muscle? Well, this intranasal naloxone minimizes the risk for bloodborne pathogens and exposure, as there is no needle. This is also administered very rapidly and painlessly, and the onset of action is 3 to 5 minutes, and the peak effect is within 12 to 20 minutes. This is not that different if you were to give it by IV or intramuscularly. They are very close in onset. It works almost as quickly as an IV route, since the nasal mucosa is highly vascularized and absorbs drugs directly into the bloodstream, as you can see in this next photo here. When we administer this, we want to make sure we compress the syringe hard and fast, is how I like to explain it, because it'll convert the liquid drug to a fine atomized mist. This results in the broader mucosal coverage and a better chance of absorption into the bloodstream. If you do not push hard and fast, as you will see in the practical portion on your final day of this EMR training, you will see that the droplets will just run straight down and it won't atomize. And the droplets will just go into the back of the throat, and we will not get that mucosal coverage. So in your kit, you will need one Luer Jet needle-free syringe, which you see here, which is on the left-hand side of your photo. You will have one ampule of naloxone, which is 2.0 milligrams or 2 milliliters, and one nasal atomizer. The first thing you're going to do is remove the caps from both ends of the Luer Jet needle-free syringe. So right there you'll see that they're both yellow in this diagram. You will then want to take your 2 milligrams or 2 milliliter naloxone Narcan vial. You're going to want to take the red cap off, screw the now open end, once where the red cap was, end of the vial into the syringe. It may be difficult to turn when it is threaded through, as there is a rubber stopper inside the vial. Then you will want to attach the nasal atomizer to the opposite end. Screw that on tightly, and then you'll have one Luer Jet needle-free syringe with naloxone hydrochloride attached. At this point, you are ready to administer the naloxone. So again, we're going to want to push hard and fast for an adult into each nostril. It's going to be 1 milligram per nostril. And then if we are to do a child or infant, you're going to want to push half of the vial hard and fast into each nostril to deliver 0.5 milligrams per each nostril. Keep in mind that if you give more or less to an infant or child, it is not going to hurt them. You are going to have the same effects, as well as that goes for the same with an adult if you were to give a second dose of Narcan naloxone, if the person or patient goes back into opiate overdose withdrawal symptoms. So what really happens once Narcan naloxone is introduced into the body when we have an opiate overdose? So, as you can see here, the green Christmas trees symbolize an opiate receptor on the brain. The opiate is now ingested, injected, or taken by mouth or by transdermal patch, and the opiate is now sitting on the receptor of the brain. When that overdose happens, we're going to have the decreased respirations. The patient's going to have agonal respirations. They could be, or most likely, unconscious, blue tinge around the mouth, and they are not breathing adequately. At this point in time, we want to introduce the naloxone by intranasally, and once it gets absorbed into the nasal mucosa, that naloxone comes in, immediately pushes that opiate off of that brain receptor, and now that naloxone starts to begin the reverse effects of that opiate. As we are waiting for that opiate to be removed from the brain receptor, we want to make sure that we always have our bag valve mask connected to high flow 15 liters of oxygen, and we want to make sure that we ventilate that patient to make sure that that Narcan is being absorbed rapidly into the body, as well as assist them with ventilations. Again, if we do not assist with ventilations, our patients are going to go into respiratory arrest, which in turn goes into cardiac arrest, where CPR now needs to be performed. We want to make sure we prevent that. Also, keep in mind the effects of naloxone may not last as long as the effects of the opiate. We want to make sure we prepare for return of overdose signs and symptoms like we reviewed. That is why it is important to try to make them go to a hospital for further evaluation. If these individuals do not want to go to the hospital and we cannot convince them for their safety, then it is important to have somebody take responsibility and keep watch of this individual in the event that they do go back into an opiate overdose. If the patient does not come around after a few minutes after the administration of naloxone, and we start ventilating them with our bag valve mask device, we want to make sure that we are going to continue to check our ABCs, which stand for their airway, make sure they are adequately breathing, and make sure they still have a pulse. If there is no pulse, we need to immediately start CPR. Once naloxone is administered and the patient begins to wake up from their opiate overdose, again, remember that they go into a rapid opiate withdrawal. With that said, the patient becomes or can become agitated, irritable, and might have violent behavior. They will have restlessness and nervousness, so be prepared to deal with that. The person in a rapid opiate withdrawal may cause nausea and vomiting. We also want to keep in mind that we can always put them in the recovery position or any position to keep their airway open and them comfortable. Now that we have placed them in a rapid opiate withdrawal, some other reactions that could happen to the patient are that they have runny nose, they start to have excess sweating, they have a fast heart rate, also known as tachycardia, they show signs of tremors, they might have high blood pressure, hypertension, or low blood pressure, hypotension, or they can go into cardiac disturbances, including cardiac arrest, or have a nosebleed. So with that said, if once they return to normal breathing and are now awake, it is good to explain to them that these withdrawal symptoms may happen, and that to make them comfortable, it will be a good idea for them to go to the hospital to kind of curb some of these opiate withdrawal symptoms that they may be having. There are two types of opioid addiction treatment drugs. The first one being methadone. It's an opiate which may be used as a pain reliever, but commonly prescribed to minimize the effects of the opioid withdrawal. There's also Suboxone, which is a combination of an opioid and naloxone, and it is used to minimize effects of opioid withdrawal while blocking that euphoria or high that one is seeking when taking opioids. We need to continue to provide respiratory assistance as needed. If respirations decrease, we obviously want to provide the supportive care. Keep in mind that naloxone is not effective against overdose from non-opiate drugs. If no pulse, with or without agonal breathing, begin CPR. We also do not want to administer naloxone to patients in cardiac arrest. There's different adjuncts that we can use to open an airway, such as an oral pharyngeal airway, as you see in the photo. or a nasopharyngeal airway, where you can see it being inserted into the nasal cavity. Those are also called nasal trumpets. Here's your standard oxygen tank, your non-rebreather mask. These are used high flow on 15 liters of oxygen. We have the one-way check valves that are located on the front of the mask, as well as the exhale port and inhalation port. You want to make sure to fill the bag prior to placing the bag on top of the patient to ensure proper oxygenation. This mask you do not want to put on an unresponsive agonal breathing patient due to them not being able to properly ventilate themselves. In this scenario, you would like to use a bag valve mask, which will provide adequate chest rise and fall and assisted ventilations on somebody who is agonal breathing. Here you see that the physician is using the CE clamp method, allowing for a proper seal, as well as a head tilt chin lift that allows for the airway to be opened. And this is your standard bag valve mask with the mask, the bag, and the oxygenation cord where you would apply to the oxygen tank, high flow 15 liters. And then you will do your practical portion where you will properly measure an oral pharyngeal airway, nasal pharyngeal airway, learn how to use the non-rebreather mask, bag valve mask, properly learn the CE clamp method, the use of the oxygen tank, as well as the Narcan nasal atomizer. In summary, we have learned what an opiate overdose presents like, what the signs and symptoms of an opiate overdose are, the indications and contraindications for administering naloxone, the possible adverse reactions of naloxone, how to manage these adverse reactions, and how to prepare a naloxone atomizer or how to administer the naloxone via auto-injector.